Today, we are delighted to welcome Dr. John Flaherty, Professor of Medicine at Northwestern's Feinberg School of Medicine, back to our alumni podium today for his timely thoughts on public health challenges in an era of misinformation. A bit of background. Dr. Flaherty is a graduate of the University of Notre Dame and received his medical degree with honors from the University of Illinois. He completed his fellowship in infectious disease at the University of Chicago and joined here at Northwestern in the medical faculty in 2001. He's currently a professor of medicine and a professor of medical education. And not only is he an invaluable mentor to medical students, residents, and fellows alike, Dr. Flaherty has consistently been named year after year as one of Chicago Magazine's top doctors. Now, one other thing, Dr. Flaherty has another interest on a different stage. He's got a rock and roll background. He is currently the lead guitarist in 3 different bands. He has jammed with med students to rock his guitar in the Feinberg variety show band called the Hypochondriacs. He performed a crowd-pleasing guitar solo which brought the entire audience to their feet, and so it turns out that while infectious diseases might be his professional specialty, he has a serious musical talent which is also very contagious. It's this rare combination of great skill, compassion, and good humor that makes us feverish to have him speak with us again today. So please welcome Dr. John Flaherty.
Thank you very much. That was a wonderful introduction. It's a pleasure to be back with you. I think this is my 3rd or 4th time over the years. So I was kind of offered, like, what do you want to talk about? And this was on my mind back when Carla Stone invited me to give this lecture again. And it's become more on my mind since I told her back, that was probably in March or so when she invited me to do this. But I'm not a public policy expert. I'm an infectious disease doctor. I'm a clinician and an educator. I take care of patients and I teach. I've done a lot of teaching over the years. Been in charge of the microbiology curriculum at the Northwestern Feinberg School of Medicine for about 13, 14 years. I've been a fellowship program director, both at the University of Chicago and at Northwestern for 25 years. So I'm very invested in teaching, and I'm very invested in my patients. So I thought what I would do today is sort of give you a little, kind of an overlay of my career. And a little bit, relevant disclosures. I have no connections with pharma manufacturers. I am on the CVS Health Pharmacy and Therapeutics Committee and have been for the past 23 years. And I co-author a vaccine book, which informs a lot of, I think what we'll talk about today. So I have had a career. I've been an infectious disease doctor now for 37 years, and my career has been bookended by pandemics. So you probably know where this is going. So this is 1981. Now, I was a second-year medical student, so I'm sure this was not on my radar. But this is the first report of what became AIDS. So a group of men described in Los Angeles with pneumocystis pneumonia. Pneumocystis is a fungal infection that we see in people who are very immunocompromised. And up until that point, it was very rare. And suddenly we started seeing a lot of cases of this. In 1983, investigators in France identified the cause of this syndrome. And it was later named human immunodeficiency virus, or HIV. And this electron micrograph shows some of the virions budding off the surface of a lymphocyte. So let me tell you, my first exposure to this, as I recall, I was an intern at the University of Iowa. And I had a young woman admitted to my service. She was in her mid-late 20s. She was from Iowa City originally, but had moved out to San Francisco, and then had gotten sick and moved back to Iowa City to be with her family. She was incredibly ill. She had multiple opportunistic infections, these kinds of infections that you see only in people who are very immunocompromised. A lot of times in medicine we cite Occam's razor, which is that the simplest explanation is usually the right one. People in the advanced stages of HIV infection with AIDS, they defy Occam's razor. They often have multiple opportunistic infections at the same time. And this was true for Angela. She was very sick. I also remember that I had a big team, an attending, resident, interns, medical students. But every day they would have me gown up, put on like a mask and a hat and booties and a gown and gloves, and I would go in, and they'd all wait outside. And they'd wait for my report. How's she doing today? Because everyone was so frightened. People weren't sure. How is this transmitted? What's going on here? It stands out to me that she was really left alone in that room, except for the times that her nurses and I would go in and see her. That happened again towards the end of my career. We'll talk about that pandemic too. This was a terrible time. So she died. I went into infectious diseases because I thought it was so interesting. And for the first 8 years of my career, my patients died. I saw patients every 2 weeks, maybe every month. They always came with their families because the families came there at the end. And there's very little we could do for them. We could treat these terrible infections as they came, but we couldn't really reverse the underlying process. And so those are dark times. Just as a little bit of background, because I teach medical students, so I'll give you a bit of my medical student teaching shtick. So AIDS, acquired immune deficiency syndrome. So this is the syndrome that was initially described back in 1981, where the immune system is kind of wrecked. And they further defined it as when your CD4 count, your helper lymphocyte count, gets below 200, which is somewhat arbitrary. Or you had evidence of one of these weird opportunistic infections. So for a couple of years, that's all we knew. There was something happening. And then, as I said, the investigators in France, and then reproduced by investigators here in the US, identified this virus, this retrovirus, which had a tropism, meaning it targets CD4 positive lymphocytes. And that happens to be a particular kind of lymphocyte, a particular kind of T cell that's crucial for the functioning of the immune system. But it also, when you lose those, you become at risk for particular kinds of opportunistic infections. And this image here, again, shows the HIV virions budding off the surface of a CD4 lymphocyte. We learned more about this, and I'll take some opportunities to brag on some of my colleagues a little bit. So we know, for example, that HIV is a zoonotic infection, meaning it comes from animals. The dominant pandemic strain, HIV-1, comes from chimpanzees. So it's a disease that has been in chimps for tens of thousands of years and then crossed over into humans and created this pandemic. There's another one you might not have heard of, HIV-2. This is a simian immunodeficiency virus of the sooty mangabe. It's a much more minor player. Work by one of my colleagues, Stephen Walensky, who we were a team together for 17 years when he was the chief and I was the associate chief. Steve recruited me to Northwestern. But he has a really impressive lab. And they do sequencing, among other things, of HIV virus. And they were able to obtain samples from the basement of a hospital in Kinshasa in the Congo. And they were able to extract HIV from those samples from 1960 and 1959. Those are the earliest documented known samples of HIV that we have. And by sequencing strains that are present today, or present at the time of this paper, and those earlier strains, they're able to back calculate when HIV entered into the human population. Because, like another virus we'll talk about, HIV mutates continuously. And it's at a sort of a regular rate. So you kind of appreciate how it's, I'm sorry, I'm going to back up. How it's, you can actually time, when two strains have diverged by virtue of how different their genetic makeup is. And so Steve and his lab and all his collaborators were able to confirm that it had crossed over from the chimp into the human in the early 1900s, maybe 1908, which I think is fascinating. And then further, some of his collaborators were able to demonstrate where this occurred. So they collected samples from troops of chimps in West Africa, and they were all able to identify, that if you see those little arrows in the bottom there, those, the chimps there, their simian immunodeficiency virus was an ancestor of the simian immunodeficiency virus that crossed into humans. So they were able to back calculate somewhere in around 1908 that there was some exposure that transmitted HIV to humans, and it spread from there. Undoubtedly, there have been other crossovers over the years, but none of them really took. So this was a kind of a terrible time for a long time. And then I managed to keep this. This is my Newsweek subscription back from 1996. And so there was a change. Up until that time, we had some medicines, but they didn't work very well. And then we started using this combination therapy with the introduction of the protease inhibitors. And things really transformed. So I'm going to tell you about a success story. So Lisa was 26 when I met her in 1993. She was pregnant with their third son when she developed a severe pneumonia and respiratory failure, was transferred from an outside hospital to where I was at the University of Chicago, and she was diagnosed with pneumocystis pneumonia. So that's that weird fungal infection. Now, as far as we knew, she was otherwise healthy. Well, she wasn't healthy. So when we investigated further, she had HIV infection and had a very low CD4 count. She survived that pneumonia, gave birth to her son, who was HIV negative. Her two younger sons were also HIV negative, which is, which was wonderful. But this was 1993, so that those potent medicines weren't coming for a couple of years. And over the next 2 years, she continued to deteriorate to the point where at late 1995, she weighed 85 pounds. Her CD4 count, now a normal CD4 count is probably like 1,000 or 1,200. Her CD4 count was 1. So she told me she was going to go to Disney World with the 3 boys, and I supported that. And I thought this would be her farewell tour. So off she went to Disney World, but boy, she was a fighter. So when she came back, though, these new medications were available. And she was all for it, of course, and so we put her on it, this therapy, and I saw her now in August. She weighs 140 pounds. She has 5 grandchildren, and her CD4 count is 1,200. So she made this was like a Lazarus kind of situation where she really came back from the dead. And it's always such a joy to see her, and her husband, who had HIV infection. Turns out he had a blood transfusion when he was a teenager before they were testing. And, so they were completely unaware of this. So remarkable success story. This was further documented at the time. This is from the HOP study, the HIV outpatient study. And it shows how the death rate plummets in early 1996 in patients who are on these protease inhibitors, on this combination therapy. It's also called highly active antiretroviral therapy. So another shout out. So the PI of this study is Frank Palella, my colleague and dear friend. This has been extended, so over the years you can see that as the number of patients are on this highly active antiretroviral therapy, the death rate has fallen even further. I mean, you can see it's going down to near zero. This has been amazing, right? So we always talk about the bad old days and the good old days. In terms of HIV infection, for my practice, it's the good days. People are doing great. You probably see these on TV now, the ads, right? So the most common regimens we use now, one pill once a day. I will say, but back in the day, back when Lisa first started on her therapy, it was tough sledding. That you would have to take multiple pills many times a day, lots of side effects. Today, not so much. One pill once a day, and they work great. There's even an injection. You can get an injection. It's actually one in each body every 2 months, and that works great. So then you don't even have to, people who have trouble taking pills or can't remember to take pills, even we can treat them effectively. So it's really the good times. And it's getting even better. So this is showing that as people have entered care from, say, 2000 to 2012, the gap in terms of lifespan between people who don't have HIV infection and people who do keeps narrowing, such that if someone enters care today, they're likely going to have a normal lifespan as long as they can take the medication. There are some issues, though. Not everybody's in care. There's still a fair number of people out there that have HIV infection who don't know it. That's that diagnosed, so 87%. This is the last time we have data for this, which is published in 2021. And you can see that not everybody's in care. So we still have some work to do to try and capture those folks, get them in care, and get them on treatment. If we can get them in care, though, we can almost always suppress their virus, and they can remain well. But this is age-adjusted rates of death in the general population. Again, showing how it's declined dramatically from the bad old days of the early 90s. So just to kind of summarize, so it entered the human population, 1908 plus or minus, that's an estimate. The first documented case now is that case in Kinshasa in the Congo, 1959. There have been 88 million people who have been infected, 44 million deaths. And currently today, there's about 40 million people living with HIV infection. There were still 630,000 deaths related to AIDS in 2024. But that's down from almost 2 million in 2004. So we're making progress. And still 1.3 million new infections. So we haven't solved this. We've still got a ways to go, especially globally. But we have a lot more people on or have access to antiretroviral therapy, and I'll talk about some related to that. So just to narrow down to HIV in the US, first case, we think 1971. That's the first documented case. 1.3 million persons living with HIV infection in 2022, last year we have data, but 13% are unaware that they're infected. So we can still do a better job of trying to capture people, get them tested. And 31,000 new infections in 2022. That's down from 130,000 new infections back in the mid-'80s. Estimated 700,000 deaths. But notice, 2023, 4,500 deaths related to HIV in 2023, but that's down from 45,000 in 1995, which is kind of the turning point. Just to highlight another thing. So treatment not only benefits the individual who's infected, but it benefits the rest of us. So that it's treatment as prevention. You may have seen this, U equals U. So there have been 0 transmissions of HIV from an individual with HIV infection if they're suppressed on therapy, if they're undetectable. So that's undetectable means untransmittable. So that's a benefit to society, that we get everybody that we can who has HIV infection on therapy and get them suppressed. You can sort of take the other side of this too and treat people who are at risk. You've probably heard of PrEP, pre-exposure prophylaxis. This is people who may be at risk, who recognize that their behaviors might put them at some risk, and they take some medicine every day. And it works. If you take the medicine, you don't get infected. The trick is people who are not infected are not always so motivated to take a medicine every day. So it's a challenge. And we've seen that in many studies where the adherence is not so great. So I just want to tell you about this new drug that just was approved, lenacapavir. So this is an injection you can get every 6 months, one injection, and it's amazingly effective. So there was one study in Africa where the baseline was that about 2.5% of folks got infected over a period of time if they weren't on any treatment. The folks that got the lenacapavir injection, it was essentially zero. And that has been approved now as prevention. So there's potential there. Why don't we have an HIV vaccine? There have been lots of vaccine trials over the years. There's more than 20 in process now, and none of them work very well. So why is that? So there's no natural model of protective immunity. Most of us, if we got measles when we were a kid, then we're protected from measles again. If you get HIV infection, you don't develop protective immunity. So there's no model for that. The nature of this virus is that it creates a DNA copy of itself that's inserted into your chromosomes. How are you going to get that out of there? And it exhibits enormous genetic variability. As another virus that we're going to talk about, it mutates constantly. That's how they were able to identify where it came from and when it entered humans. But it also evades our immune system. And it's really obviously a tough nut, right? Because we've been talking about vaccines for the past 35 years, and we're really not any closer. There's some other challenges I'd like to mention. So one is persistent inflammation. Even if your viral load is undetectable, there is some low level of viral replication going on, and that creates inflammation. And we know that inflammation drives aging. It drives atherosclerosis. So it's another risk factor for cardiovascular disease, for example. It's probably another risk factor for neurocognitive decline. So while people are living longer, living much closer to a normal lifespan, it's not quite there. And then you don't really recover everything. Depending on when your infection is recognized, your immune system can harbor some damage that it can't reverse. And so we still see some, for example, some malignancies in people that we wouldn't expect to see. And then access to therapy. So that's still an issue. As I said, in the US, there's still people who are not entered into care, so they're not on therapy. Globally, it's a much bigger issue. So that brings me to PEPFAR. So PEPFAR, the President's Emergency Plan for AIDS Relief. So this was announced by President George Bush in 2003 State of the Union address. And it's the largest commitment by any nation to address a single disease in history. So it supported care, treatment, testing for folks with HIV infection over 50 countries. The estimates are it saved more than 26 million lives. prevented 5.5 million babies from being born with HIV, increased life expectancy in sub-Saharan Africa, which has been so severely impacted by the HIV pandemic, from 56 to 62 years over the course of 14 years. And in 2024, it was providing treatment for over 20 million people, including 500,000 children. It was also providing new initiations on PrEP, that's the pre-exposure prophylaxis, that amounted to 90% of the new global PrEP initiations. So I think dramatically effective. And I think in no small part, due to PEPFAR, the global deaths, which we were predicting back in the 90s, we were predicting it's going to be a complete disaster. There was actually, one of the motivations for PEPFAR was humanitarian. Maybe that was the dominant motivation. But another important motivation was security and stability, because there was a concern that Africa would be completely, chaos, devolved into chaos, because all the people of the sort of the working age, parent age, with HIV infection were going to die, and it would just kind of gut societies and create chaos. So anyway, that's been blunted and reversed. And here I get another sort of shout out to a couple of my colleagues. So Robert Murphy, he was the country director for Nigeria. He basically started PEPFAR in Nigeria and served as the country director for 2004 to 2010 until he could hand it over to the Nigerian physicians. Claudia Hawkins, she was my fellow, so I trained her back in the 2000s. And then she took a position as the clinical director for Tanzania from 2007 to 2011. And so started the PEPFAR program in Tanzania. And both of them still work with Africa on these things, but now act as consultants, because they basically handed over the management to Nigerian and Tanzanian physicians. You might recognize Dr. Murphy from his appearances on WGN during the COVID pandemic. Anyway, he couldn't travel to Africa anymore, so he started doing stuff locally. Well, that's kind of changed. That's a little bit in doubt, right? So they basically, slashed USAID, and USAID was administering PEPFAR. So there's lots of these headlines I took from the New York Times. So they really gutted the HIV program. They've gutted PEPFAR. It's still on the books to some extent, but by eliminating all these staff that used to administer it, it's really, some countries have no access to medications, and some are kind of working along, trying to keep it going. So this is the budget request for 2026. That would be less than half, but even the budget for 2025, it's been difficult to implement because you don't have the people on the ground to make this happen. Oh, and I'm not an economist, but USAID spending in 2024, $22 billion, which is 0.3% of overall federal spending. PEPFAR is 0.1% of overall federal spending. So I guess we get to make decisions about what we want to do with our money, but it seemed like a small amount with a big effect in a program that I was very proud of. I was proud that I have colleagues that were so instrumental in making it happen. So it troubles me to see what direction we're going in. So I'm going to summarize this part. So antiretroviral treatment, well tolerated now, really works. There's still some folks out there that have it that don't know it. It's still hard to get everybody into care. There's no cure, there's no effective vaccine on the horizon. So it's all about getting people on treatment. there's still some issues, but but life has improved dramatically. Okay, and progress controlling the HIV pandemic globally is now, I think, in jeopardy. All right, another pandemic. This is more, I think, more near in our memories, right? I don't see too many masks today. So digging back, so this was January 8th, 2020. China identifies new virus causing pneumonia-like illness. There is no evidence that the new virus is readily spread by humans, which would make it particularly dangerous, and it has not been tied to any deaths. Well, right, I mean, we've got to see how things play out, right? So you know what's coming, right? So this is a few days later, they confirmed, oh, I guess it does spread from humans to humans. In recent days, at least 2 people have become infected with the pneumonia-like virus, even though they live hundreds of miles from Wuhan, suggesting that the illness is spreading from person to person. So I'm going to take you back. So this is, when I think about the start of the COVID-19 pandemic, I always go back to our journal club on January 28th, 2020. So my colleague Shannon Galvin, brilliant clinician, and actually who really led us through the whole COVID pandemic on the clinical side. She and I were assigned to journal club that day. So she called me up, she said, should we talk about this virus from China? And because there were some papers published in Lancet this week. So she took a couple of papers, I took a couple of papers. These were my papers that I talked about. So we talked about these papers in journal club with all our colleagues. There was a photo essay in the New York Times a few days previous, and I showed these photos. So I go back, and I was looking at the context of these photos and then this familial transmission of the virus. We sort of talked, ruminated about this, and we all got a sense of dread. So we walked out of there saying, this is going to be bad. And I remember we'd see friends and they'd say, what do you think? Is this going to be anything? And I said, this is going to be bad. And you could see it coming. So here's Robert to tell you. So it really hit us in March. There were cases a little earlier. In Washington State, there was a case in late January. But we didn't really start seeing cases at Northwestern Memorial Hospital until mid-March. And so here's March 19th. Robert, who was a gentleman in his late 60s, came in with fever, chills, body aches, generalized weakness, loose stools. We couldn't test him. There were a limited number of tests at the time, and he didn't meet the criteria because he hadn't been to Wuhan. Now, interestingly, 2 of his daughters were nurses. And so they kept tabs on him. And they brought him back a week later, and you can see his x-ray is a lot worse. And he had to be intubated in the emergency department. Now, we wouldn't have changed anything if we admitted him. We swung and missed, but this was coming. We didn't have any treatment for this, so this was going to happen, which is sort of discouraging. And actually, we did the nasopharyngeal swab. You've all had those, right? Where they jam that swab into your brain. And we don't do that anymore, by the way. But that was negative. Interesting. But he was so sick and got intubated so they could do a bronchoalveolar lavage. So his BAL test was positive. So he met the criteria, I guess, by being intubated. But he was admitted to our intensive care unit, and he remained intubated for about 3 weeks and recovered because we have such brilliant intensive care unit doctors and nurses. They were so great. People would call me up and say, I remember a good friend of the family's on Easter that year called up and said, he's tested positive, and now his O2 sat, which, we bought those O2 sat monitors. He was monitoring his at home, and it was diving down in the 80s. And he said, should I go to my nearby community hospital? I said, no, go to Northwestern. and went to Northwestern. He was also intubated for a couple of weeks and survived and is doing well today. But anyway, I shout out to our intensive care unit folks because they did an amazing job. I mean, our mortality rates were much lower than I think than other hospitals. So he survived, but this is what we started to see. And before you know it, we were flooded with people with, I mean, we all lived through this, right? It was terrible. But to be kind of on the front line of that was really scary. And you'd see, usually people about a week into the illness, they would crash. And then off to the intensive care unit, get intubated, and try and support them. Shout out to my daughter. I should have put a picture of her. My daughter, Claire, she is a nurse on the pulmonary ward, was recruited to one of the many new COVID intensive care units, and then transitioned to be an intensive care unit nurse, and then since then she actually got her nurse practitioner degree. But she was in the thick of it, caring for patients with severe COVID throughout those years of the pandemic. She would tell stories about how she would go in with an iPad so that the patients could say hi to their family members, sometimes say goodbye to their family members. That was a tough time for all of us. We may not acknowledge it, but there's a lot of grief there. That was really a tough time. So complications. So the main one was respiratory failure, and it's typically in the second week of illness. And then all these other things, yikes. Venous thrombosis, so pulmonary emboli, blood clots, myocardial infarctions, strokes. That was all, much of that was related to COVID. Myocarditis, neurologic complications, kidney injury. This unique kind of weird thing, multi-system inflammatory syndrome, MIS, which is especially in kids, which is like weeks after the illness. So they get COVID, and then like 4 weeks later, they would develop a severe multi-system illness. And then long COVID, post-COVID. Most of us know somebody that experienced this, maybe still experiences. So this is from my medical student talk. Enveloped single-stranded RNA virus, which has a feature of mutation and recombination. So we talked about that with HIV, right? That it frequently mutates and evolves like crazy. The same thing with SARS-CoV-2. It mutates like crazy. But it not only mutates like point mutations, but also swaps whole segments of its RNA genome. So it can change in sort of marked ways in no time. There are several, they're listed here, 4 human coronaviruses that are the common cold that most of you have had once or twice or maybe several times through your life. And it's really very mild, not a big deal. We're more aware of it now because of our diagnostic panels include those viruses. So we find out that people have these human coronavirus infections, but it's no big deal. This other group, this group 2B SARS-like coronaviruses, so you remember SARS, right? So that was a kind of a here and then gone very quickly, right? There was a number of cases in Toronto, cases in Hong Kong. It didn't, because it wasn't that easily transmitted human-to-human, so it was fairly limited. Then MERS, that's still percolating out there. That's the Middle East respiratory syndrome. Comes from camels. It's still out there a little bit, but it didn't really get going. But SARS-CoV-2, well, we all experienced that. And there's the electron micrograph of the SARS-CoV-2, and you can see those little nubbins on surrounding the virion, and those are the spike proteins. And that's how it attaches to the respiratory cells in our system. So a shout out to my colleagues. So Dr. Egan Ozer, Dr. Judd Hultquist, and Dr. Ramon Redondo. So these guys, Egan was a bacteriology guy. And Judd and Ramon are HIV guys. And they turned their labs around over a period of about a week to become COVID labs. And have published dozens and dozens of papers They've sequenced thousands of isolates of SARS-CoV-2 from the Chicagoland area, and now they're sequencing viruses from all over the world. I'll just pull this graphic at the bottom right that's showing how the different strains are moving through Chicago. So it's incredibly complex, and it affected how we dealt with the pandemic. So first reported December 2019. Worldwide, there have been almost 800 million cases. This is documented, and documented 7 million deaths, probably more than that, but this is what's been documented. In the United States, 111 million cases, 1.2 million deaths, again documented. There's some estimates that it's probably higher than that, and caused tremendous social and economic disruption. So I just want to COVID grief. I thought this was an interesting concept. I think a lot of us either overlook it or suppress the idea that that was a really, really difficult period. And so many of us had direct connection with this, the deaths of loved ones. All of us were isolated from family, friends. It really kind of wrecked our lives for a long time. But there was a lot of fear about it because that's logical. We had over 1 million people died just in the U.S. I can tell you, I experienced a lot of fear because of what I was seeing at work. At one point, we had over 100 people on ventilators with COVID. We had sort of turned all these units into ICUs. We borrowed ventilators from Lurie and wherever else we could get them. It was nuts. It was an all-hands-on-deck thing where I'm covering general medicine services because our doctors were getting burned out on the COVID wards. I think it's important to recognize this because I think there's an element of revisionist history now. Like, it wasn't that bad. No, it was terrible. And then people saying, oh, you kept us indoors too long, or, you made us wear masks. I don't want to wear masks. Well, people were dying like crazy. I mean, our systems were, at certain points, were kind of overwhelmed. If you might have had a surgery scheduled and then they canceled the surgery, we can't do the surgery. We don't have any beds to put you in after the surgery. Everyone's preoccupied with trying to keep people alive with COVID. So there's a little bit about COVID prevention. So this is Lindsay Heiss, who was my fellow back in 2020. So shy, strong, Chicago, there weren't any tourists, and it kind of emptied out downtown, but we were down there every day. So there's some controversy now. Do masks work? And yes, masks work. They're not perfect, and they're going to depend on how you use them, but they work. Social distancing, yes, it works. You stay away from people. I don't know if you remember that year, almost nobody got influenza. Ventilation, open the windows, improve the ventilation, that works. So there's strong and consistent evidence for preventing airborne transmission of SARS-CoV-2 and other respiratory pathogens, especially valuable in crowded indoor settings during surges of highly transmissible variants. But it depends on how you use them. N95s work better than the surgical masks, work better than the cloth masks. But all of them have some value. So there's no controversy about this, at least among infectious disease doctors. So there are other things that were useful, for example, for the first SARS epidemic. Active surveillance, contact tracing, quarantining positives. And that didn't work with SARS-CoV-2, with COVID-19. It was too transmissible, and it was too out there. There were already too many cases. It was just too infectious. So we relied on vaccination. So a shout out to my former fellow, actually my former medical student too. He worked with me as a medical student on a research project. And then I recruited him as a fellow to Northwestern. He had been a student at U of C when I was there. And then we had him on the faculty. We managed to hang on to him for a few years. And then he was recruited to Emory to run their clinical vaccine center. And now he works for Moderna because he was lead author on a number of the trials of the Moderna mRNA vaccine. So just a wonderful guy. So these vaccines were one of the most remarkable things I've ever seen. They kind of parallel Dr. Frank Palello's paper in the New England Journal, where it showed that as people were put on highly active antiretroviral therapy, that the mortality rate plummeted. You rarely see I did not expect this vaccine to be that effective. So it was really effective. Now that didn't hold, right, as the virus mutated. But up front, wow. Whoa. I mean, I couldn't have hoped for that it would have been that effective. So you can see how these two curves diverge. The folks who are vaccinated, they basically don't get infected. The people that got the placebo, they got lots of infections. So this was the Pfizer vaccine. That's the fancy name for the Pfizer vaccine. And this was the Moderna vaccine. Same thing, 94% effective. Yikes. This was so exciting at the time. I remember they sent out an email to the staff at the hospital offering slots for vaccination. This is right before Christmas 2020. Well, the email came out at like 11 o'clock at night. Well, I don't check my email at 11 o'clock at night. So I checked it when I woke up, at 8 o'clock in the morning, and all the slots were gone. So I had to go out to Wheaton or something to stand in line to get a vaccine. It's like, geez, I'm going and see these patients every day, and I can't get a slot. But that's how I embraced that vaccine. And it really did work. Now, we know as time evolved, the vaccine strains changed, right? And so they escaped some of that protection. But they really worked. I mean, look at here. You have the vaccinated with or without the booster, and then unvaccinated in the red. Yikes. We saw this in the hospital after the vaccine became available. If you were in the ICU on a ventilator, you didn't get the vaccine. By the way, there were more deaths in the US from COVID after the vaccine became available than before. And most of it was not seniors. So the seniors got in there and got vaccinated. About 90% of seniors are vaccinated. It was more middle-aged folks. So, and that's who we were seeing in the hospital, was these people in their 40s and 50s on ventilators. And no, they didn't get the vaccine. So the estimate is that without vaccination, there would have been nearly 120 million more COVID infections, 18 million more hospitalizations, and 3.2 million more deaths. Yikes. Now, it's not as effective, but I just want to emphasize it's still effective. Like, they still work. So this is last year's vaccine. This is a study from the VA hospital system. So they have thousands of people, right? So some of them said, I'll take the flu shot, and other people said, I'll take the COVID and the flu shot. I still have the patients today, I saw in clinic last week, who said, the flu, yes, COVID, no. Okay. So notice, we don't see 95% effective, but still 29% effective against ED visits, 39% effective against hospitalization, and 64% effective against death. So if you look at any one year for influenza, the flu shots generally are about 50% effective. They're not 100%. I mean, But you're less likely to end up in the hospital, and you're much less likely to die of the flu. And so it appears it's the same with COVID. It's not going to 100% prevent you from getting COVID again, but it's going to be a lot less severe. So let's talk about vaccines a little bit. So I give the vaccine talk to the medical students, and so I took some of my slides from there. So they're one of the great public health achievements of the 20th century, and now 21st century. They're safe and effective. They're neither perfectly safe or perfectly effective. So you don't want to oversell. And I think that's the sense of with the COVID vaccine. People felt it was oversold. Like you said, it was going to make it go away. We hoped, but we didn't have that data. So now we have that data. And if you thought it was going to make COVID go away forever, it was oversold. I don't remember saying that or hearing any of my colleagues say that. So just dip back in time a little bit. So smallpox, variola major, 20 to 60% mortality, greater than 80% in children. Estimated 300 to 500 million deaths during the 20th century. 1967, there were 15 million cases, 2 million deaths. That's not so long ago. I think many of you in this room were alive in 1967. But it's been eradicated. So, I mean, if you need to claim one victory for vaccines, this would be it, right? So they discontinued vaccination in the US in 1972. Last naturally occurring case, October 77. Certified eradicated in 1979. Now they have it in some labs somewhere in the US and somewhere in Russia, but so far so good. It hasn't gotten out. Oh, this is from our vaccine handbook. Did you know Abraham Lincoln had 4 sons and 2 died of vaccine-preventable infections? Eddie died at age 2 from diphtheria, and Willie died at age 11 from typhoid fever. In 1921 in the US, there were over 200,000 cases of diphtheria, resulting in 15,000 deaths. 20% of children under age 5 died from diphtheria. And I think a lot of people today are like, why am I getting this vaccine? Well, diphtheria hasn't gone anywhere. It's still there. I mean, the bacteria is still around. We just don't get sick from it because we got the vaccine. So this is a table that you can still see on the CDC website, at least for now. And it's just kind of illustrating, if you look in the column pre-vaccine era, how many cases there would be in a typical year, and then in 2024, how many cases there were. You can see a fair number of cases of pertussis because we went from a whole cell vaccine to an acellular vaccine, which it's better tolerated, doesn't work quite as well. So another reason why, as we get older and we have grandchildren, you want to make sure you get your Tdap because you want to be protected against pertussis so you don't give it to your grandchild. But those other numbers, pretty effective, right? 100%, 99%, 100%, anyway, you can read those numbers. By the way, tetanus is still out there too. It didn't go anywhere. It's just we get vaccinated for it so we don't see it. And here's some others. So hepatitis A, hepatitis B, pneumococcal disease. Anyway, lots of, varicella. I was a bit skeptical of varicella. So my children did not get the varicella vaccine. Sorry. The vaccine works pretty good. And you're much less likely to get shingles as you age than you would if you got the sort of natural infection. Just a few graphics. So when I was a medical student, resident, fellow, young attending, the most common cause of meningitis in children was Haemophilus influenzae type B. So the vaccine was introduced in the mid-late 80s, and it's almost disappeared. We almost never see it anymore. Like dramatic. Meningococcal disease, another important cause of meningitis. One of my best friends in college died from meningococcal meningitis. I wonder sometimes if that was a motivation for me to go into infectious disease. But so again, in the mid-90s, the meningococcal vaccine was introduced, and now they vaccinate adolescents and they vaccinate kids going off to college, and the number of cases has plummeted. Hepatitis B, this has gotten a little bit of press recently. So hepatitis B vaccine, it's gone way down. Did you know Charles Bronson? You guys know Charles Bronson? James Brown, Godfather of Soul. Leo Tolstoy, author of War and Peace. Rene Descartes. And Boris Karloff all died from pneumococcal pneumonia. They used to call this the old man's friend. It didn't sound friendly to me, but and hey, this is for humorous. So in 1911, Sir Almroth Wright, a scientist renowned for his work developing an effective vaccine for typhoid, was sent to South Africa to develop and test a pneumococcal vaccine in order to alleviate the burden of epidemic disease in gold miners there. Despite vaccinating over 50,000 miners and claiming his results showed that the vaccine worked, it didn't hold up well to scrutiny. That left him with the unfortunate nickname Sir Almost Right. All right, can't all be doom and gloom. Okay, so talking about pneumococcal disease, this is kind of interesting. And so the pneumococcal conjugate vaccine, or PCV, was first introduced in kids back in the late 90s, 2000 maybe. And what's interesting here is that these graphs are showing the rates of disease in seniors, not kids. So it was so fascinating. If you vaccinate the kids, you protect grandma and grandpa. Isn't that wild? So this vaccine not only offered protection to the individual who got the vaccine, but offered broader protection to people around them. Because these conjugate vaccines interfere with colonization as well as disease. And then when they introduced the PCV13, then the types that were covered by the PCV13 and not the PCV7, those also decreased in seniors. Again, they didn't get the vaccine yet. Now you probably had the opportunity to get to the pneumococcal conjugate vaccine. Now we're up to a PCV20 and a PCV21. And it offers a little bit of additional benefit, but most of the benefit is probably acquired from getting your grandkids vaccinated, which I think is really fascinating. HPV vaccine. This is a cancer vaccine. It's really fascinating how it works too. So they can synthesize the major structural protein of the viral capsid. That's the coding of the virus. And it self-assembles into these little virion-like particles. They're not viruses because there's no genetic material in there. There's no DNA. But to the immune system, they look just like the virus. So you can inject these in, and the body will respond to it as if it's been exposed to the virus, but it's harmless. So they're up to a nonavalent, so 9 different types. There are lots of types of HPV, but you can cover 9 of them with the current Gardasil 9. It's a 2 or 3 dose series, depending on when you start, and it's really effective against vaccine strains. And interestingly, we thought there'd need boosters, but so far you don't need boosters. It works. And it's really significantly impact the risk of invasive cervical cancer. I remember my brother and sister-in-law weren't going to vaccinate their kids because, I don't know, they were going to remain chaste or something. And I said, it's a cancer vaccine. You don't want to take a risk they'll get cancer. So I think we got them vaccinated. That was a long time ago. But here you can see, especially if you're vaccinated early, that's the green dotted line, almost no invasive cervical cancer, whereas those unvaccinated, it just goes up and up and up. I included this. This is actually from the FDA approval of the HPV vaccine, just to illustrate something. Sometimes people get a vaccine and then they experience some symptoms afterwards and they say, that vaccine caused this. This was kind of interesting. So HPV vaccine and a fair number of people got placebo. I don't know, stuff happens to people, whether you got a vaccine or not, so I just thought that was interesting. There were a lot of things attributed to the HPV vaccine early on that were, again, it was coincidence and it has not borne out. So this is really an amazingly effective and safe vaccine. So it brings us to talk a little bit about misinformation. You could argue that this is one of the key drivers of some of the, at least vaccine misinformation. So you may have heard of this. This was a paper in The Lancet back in 1998 by Andrew Wakefield and colleagues in the UK. And they basically associated MMR vaccine with autism. It's really convoluted. And if you look at the paper, you're like, this doesn't make any sense at all. But this has subsequently been refuted by everyone. And it turns out that it was an elaborate fraud, that he had been working with attorneys representing the kids who were suing the vaccine manufacturers. So he lost his license in the UK, so he came here to the US. And he travels around to autism, support groups and things like that, and still continues to spread misinformation. So, we'll deal with this quickly. Vaccines cause autism. No, they don't. Another thing I hear often is infants. Oh, and you hear this from our own president. He said, you can't give these babies all these shots. Okay. Well, it turns out that infants have the theoretical capacity to respond to 10,000 vaccines at once. That sounds preposterous, except they're eating food, they're putting their hands in their mouth, our guts are full of microbes, bacteria, fungi, archaea, viruses. So infants, adults, we're all exposed to a huge array of foreign material every day, breathing, eating, touching, anyway. So it's no problem for an infant to respond to the vaccines that we give them. Another thing you'll hear often, natural immunity is better than vaccine-acquired immunity. Vaccines are more dangerous than the diseases they prevent. Okay, here's one example. Risk of death from measles infection. People say, we all got the measles, it was no big deal. Only 1 in 500 of us ever died. Like, really? You're okay with that? And the MMR vaccine, the risk of severe anaphylaxis, 1 in a million. I mean, it's a safe vaccine. Doesn't cause autism. And death from measles is a thing. So, parts of the world that don't have access to the measles vaccine, lots of kids die from the measles. Vaccines contain harmful toxins. So, you heard this about mercury. It's been used as a preservative. It's not anymore. It was just in some multi-dose vials of influenza vaccine, but those have been taken off the market too. They've either been removed altogether, formaldehyde, aluminum as preservatives, aluminum as an adjuvant, or reduced to trace amounts, and there's no evidence that they're associated with any toxic effects. There have been some really great studies from Denmark where they have, because everybody's in a sort of a national healthcare system, so they have access to all data on all the kids and all the adults, and they've done a number of great studies looking at the risks of aluminum, for example, in vaccines, and show no effect on health. Okay. Hygiene, sanitation, nutrition, antibiotics are responsible for decreasing vaccine-preventable diseases. Those are all wonderful. Don't get me wrong. Those are amazing, and those are super helpful from a public health standpoint. But they don't obviate the benefit of vaccines. So smallpox eradicated. Polio is almost gone, at least now, and near elimination of Haemophilus influenzae meningitis. I think probably what made COVID, so first of all, it was affecting everyone. And there was such a short time from the time they actually knew about COVID till we had a vaccine. I mean, we've never had anything like that before. It's kind of amazing. They had the vaccine done before we had a case in the US. So as soon as the sequence was published, folks at Moderna and Pfizer, BioNTech, they created the mRNA vaccine. So they had a vaccine already created before we had any cases in the US. So I think, Operation Warp Speed was really super effective and amazing. Really one of the major triumphs, I think, of science in my lifetime. So, 70% of the world's population received at least one dose of the COVID-19 vaccine, 13 billion doses administered globally. It substantially altered the course of the pandemic and saved tens of millions of lives. So in the US, almost 1 billion doses, 81% had gotten at least one dose, and 70% are fully vaccinated. So one thing you hear about, well, what about the myocarditis? And it's a thing. So as I say, vaccines are safe and effective, but they're neither perfectly safe or perfectly effective. So there are potential side effects. So myocarditis is a rare side effect of the mRNA vaccines. Most commonly occurred in young males, so adolescent, very young males, young adult males, within 7 days after the second dose. So 27 cases per million doses in males aged 12 to 24. 80% of those cases are mild, and almost all of those cases recover completely. So it's a thing. But myocarditis is also a potential consequence of COVID-19 infection. So COVID-19 infection is associated with an 11-fold higher risk of myocarditis compared to vaccination. So if you had an adolescent or young adult male, maybe you go with Novavax, which is not an mRNA vaccine. But I wouldn't overblow this risk. It's a real thing, but it's a small risk and much smaller than going without vaccination. So vaccine hesitancy ranges from doubts, concerns, and I think it's totally legitimate to be doubts and concerns. But activism against vaccination is sort of extreme. It's not a new phenomenon. It's been around forever, and often reflects, I think, especially the COVID vaccine hesitancy. I think people were experiencing grief over the pandemic, and they wanted their freedom, and they didn't like being hemmed in, and they didn't like being told what to do. Even a significant proportion of healthcare providers are vaccine hesitant. I deal with that in my clinic with patients who are doctors and nurses. So the positive impact of vaccination on health would be difficult to exaggerate. They're not perfectly safe or perfectly effective, but it's, vaccine development has demonstrated remarkable benefits, has the potential to reduce the burden of disease and the threat of future pandemics. All right, so I'm going to close with a bit about misinformation. So part of this is this health freedom narrative that, it's the government overreaching. They often blend political ideology, and so they're hard to counter. Declining trust in healthcare providers, which it is what it is. So it makes people more susceptible to misinformation. The denigrating of Anthony Fauci, I feel like Tony Fauci is one of my heroes. I've known about him since the mid-'80s. He was instrumental in dealing with the HIV pandemic. Of course, he didn't have all the information when COVID first emerged. Nobody did, right? You saw that in those articles from the New York Times where it's not transmitted person to person. Oh, yes, it is. And then it's not going to be bad. Oh, yes, it is. But, I mean, all along, I think he and the other folks at the CDC and the NIH, I think, were doing their best in a very difficult situation. And yeah, a lot of people rely on influencers now. It's kind of a new concept for me, influencers. And I watch some of these things and I think, you're out of your mind, you know. And I reserve a special place in my heart for this guy. So here's some things. There is no vaccine that is safe and effective. He claimed mRNA vaccines were ineffective against COVID. I hope I've convinced you otherwise. And pose a dangerous risk to people. I hope I've convinced you otherwise. The deadliest vaccine ever made. Promoted the use of hydroxychloroquine and ivermectin. Now, some of my colleagues, I should say, were using hydroxychloroquine in those early days of the COVID pandemic. Some of us were saying, no, we should do this in the context of a clinical trial. First, do no harm, that sort of thing. Eventually, the clinical trials were done, and it didn't work. And yet, we still had people clamoring for it. Like, man, if it worked, we'd give it to you. We want to treat people, but we want to help them. We don't want to give them something that doesn't work. So misrepresented the risks of mRNA technology, suggested COVID-19 might be ethnically targeted bioweapon that was engineered to spare Ashkenazi Jews and Chinese people. He even questioned the long-established scientific consensus that HIV causes AIDS, suggesting it's a harmless passenger virus and that promiscuity and the use of recreational drugs and even antiretroviral drugs like AZT were the real causes of AIDS. This was a thing back in the 90s, but he's resurrected it in recent years. He's continued to promote that childhood vaccines cause autism. In the face of the worst measles outbreak in more than 30 years, he de-emphasized vaccination and directed agency resources toward unproven vitamin therapies, vitamin A. Removed every member of the Advisory Committee on Immunization Practices, replacing its experts with individuals who lack basic qualifications, some of whom are vaccine conspiracy theorists. This was amazing to me because I know those guys by reputation on the panel, guys and gals. Those were the cream of the crop. They were, I co-author a vaccine book. I know who those people are, and they are true experts. So they were all wiped out, and they brought in people that I've never heard of, and many of whom have no business commenting on vaccines. Created a culture of intimidation, which is why they've lost much of the leadership of the CDC and NIH and FDA. Pressure to rubber stamp conclusions not backed by science. Denigrated the CDC staff, called it a cesspool of corruption. I have a long history with colleagues who work at the CDC. My trainees who have gone there, my teachers who have trained there. You don't go to the CDC because you want to get rich. It's a government job, and you go there because you want to make a difference in public health. And the people down there are really smart, or at least they were. So one of those papers from the group in Denmark, he demanded that the Annals of Internal Medicine retract it, and good for them, they said no. And he tells people to stop trusting experts. So don't listen to anything I've had to say to you today. So why it matters. Public health risk. So it can undermine. It's going to make it more difficult for the next pandemic. And we will have another pandemic. And it might be bird flu. And how are we going to deal with that if we've kind of eliminated a lot of the expertise surrounding that, and we've poisoned the public against a concerted response? It can lead to delayed treatment, misuse of medications, preventable illness or death. And when you oversimplify things, it's a complex. The whole COVID thing, that was very complex. And we didn't get it all right. But we're never going to always get it right. So who should you trust? So people ask. Well, you probably trust your doctor or your provider, your nurse practitioner. But verify credentials, seek a second opinion when needed. The CDC has been muted, but there's still a lot of great people that work there. The NIH, again, the leadership is a little iffy, but there are a lot of amazing people that work there. WHO, peer-reviewed medical journals, if you want, or so dare. The Lancet, JAMA, New England Journal of Medicine, they really review the papers that go in there rigorously. And then if they find that they made mistakes, they retract. They fix the errors. Academic medical centers, Mayo, Cleveland Clinic, Johns Hopkins. If anything comes out from Northwestern, I hope you trust it. Who should you be cautious about? I wouldn't say don't trust, but who are you extra cautious about? Influencers. Unverified websites. TikTok, Instagram. And that's designed to be entertaining, not necessarily accurate. And in fact, they've withdrawn from the idea of they're going to police the accuracy of their material. Like, hey, what can we do? It's what the people want. And then, for now, the ACIP. Of course, they would have been among the most reputable organizations 6 months ago. Now, the consensus among infectious disease doctors is that we're not going to trust what they say. So organizations are kind of banding together to develop their own guidelines. So I'd be cautious about them. And some of the stuff they come out with may be completely appropriate, but I would just treat it with caution. So it's a brave new world. It's a bit unsettling for someone like myself, who's been doing this for a long time. But I'm confident that we're going to get through this. Oh, I might say too, they're dealing with funding cuts, policy changes. So they terminated contracts for the mRNA vaccines worth $500 million. Northwestern, the School of Medicine, and has not gotten any NIH grant money since March 26th. So they froze all of our money. Thankfully, we have a board of trustees that wants to support the ongoing research here, so they've been kind of filling in in the meantime, but that can't continue indefinitely. They proposed a 40% decrease in the NIH budget and a policy placing a 15% cap on indirect costs, which will really hamstring medical research in the future. That's really a dramatic decrease. All right, so my last slide here. So we've got emerging, perhaps re-emerging HIV threats, maybe flu, maybe Ebola will come back. We got vaccine hesitancy. We got some folks rejecting social distancing and masks. Promotion of unproven treatments, ivermectin, hydroxychloroquine. And we've been defunding infectious disease research with a fervor in the last 6 months. So, as I say, I'm concerned, but I think there are too many good people out there, and we'll get through this. So, thank you.
We have time for a few questions from the audience.
We have a question from Zoom. Do you have any professional opinions about how the COVID infection moved into the human population?
Well, I think it's a bat virus. So we know there are folks that actually study bats and isolate coronaviruses from bats, and there's a whole family of bat coronaviruses that are primed to cross over from bats into humans. Now, was that, and this is, of course, this has happened before. The SARS virus crossed over from a bad virus via a civet, which is like a small rodent. The MERS coronavirus is a bat virus, and the intermediary was a camel. So we're not sure, was there an intermediary in that live market in Wuhan? Were they studying it in the virus lab in Wuhan, and one of the investigators got infected and then brought it home? I think there's pretty good evidence that this was not engineered. My colleagues that do this, that sequence the virus, the folks that I showed you, they assure me that this is really a natural virus. But how it got from a bat into humans is not clear. So I remain open to more data.
Very nice talk, thank you. During the COVID pandemic, various countries adopted their own way of doing things. Various states did their own thing, like Florida. So have the epidemiologists actually gone back and looked at what is the successful approach that a country or Florida used or Sweden used or China used?
Yeah, it's a great question. So I think people are looking at that, have looked at that to some extent, or continue to look at that. So the places that locked down and had more stringent social distancing, mask guidelines, did better. Russia was kind of go your own way, and their mortality rate was twice the US. Canada was stricter than we are, and their mortality rate was half of what ours was. If you look at states, I mean, the states that kind of locked down, had more stringent control measures, did better, at least until the vaccine became available. Once the vaccine became available, that was really the determining factor. If people were getting vaccinated, then the mortality rates went down.
We have another question from Zoom. Do you have confidence in the flu vaccine formulation for this year, considering what has happened at the CDC? Also, where do you still wear a mask?
Ooh, that second one's tough. Let's see, I'll go with the influenza. Influenza is always a crapshoot every year because the virus is mutating all year round. They guess what it's going to be like in February because they need a lead time to be able to grow the traditional vaccine is grown up in chicken eggs, chicken embryos. So it's a guess. And most years it's somewhere between 30 and 60% effective or something like that. So, and I always have to wait until it happens because we don't really know. So I don't know. It's a guess. I think that the people involved in selecting the strains were not the ACIP. So it's other people, and it involves a lot of global partners, and so I have more confidence in that process. When do I wear a mask? I wear a mask in clinic every day, the whole time I'm in clinic. And it's really not to protect me, but it's to protect, we have patients who have had lung transplants or liver transplants, or they're on chemotherapy for cancer, and we want to make it a safe space for everyone. So, if people come into the office and they're like, I don't want to wear this mask. So when you're in the room with me, I'm okay, take your mask off. But otherwise, I'm wearing a mask. I would like to say that I would wear it when I'm on a plane, but we went to Mexico City for a wedding recently, and I didn't wear a mask. God, I hate wearing a mask, right? So, they say, and it's not harmful, but it's unpleasant, and I'm wearing one in clinic every day. So I'd like to say I wear more than I do, but I think, that's a decision we're all making. If you don't want to get influenza when you're in a crowded setting, maybe wear a mask. If you don't want to get COVID in a crowded setting, maybe wear a mask.
I have a question over here. Your HIV numbers back at the beginning of the talk suggested there are still a lot of infected, untreated people in the U.S. My question has to do with whether or not that's a socioeconomic issue, whether or not their medical coverage covers the treatments, or whether or not whether or not they have access, whether or not it would be covered under Medicaid or.
So I'm sure there is a problem with access to care, where people don't have primary care providers, they don't have insurance, so they don't take advantage of that. All of their care is going to the ED when they're acutely ill, because maybe they don't even qualify for Medicaid. If you have HIV infection and you get to us, we can take care of you. And there's a system for providing medications. So no one gets turned away. If we can get them and diagnose them, we can treat everybody. So people might just not take advantage of the opportunity to come in and get tested.
Another question from Zoom.
Thank you for your lecture today. Oh, sorry.
Oh, go ahead.
Can you give us some information regarding the studies that are going on regarding long COVID?
Yeah, we're one of the centers that has a long COVID kind of research center. And I would like to tell you there have been some great advances, but it's still pretty much a black box. So it's more observational, because looking at people's immune systems, doing a whole battery of blood tests, and then watching people over the course of time to see what happens to them. I will say that a lot of people get better, but not everybody gets better. And so it's one of those mysteries. It's if nothing else, it's another reason to get vaccinated, because you don't want to get long COVID. But it remains, I think, a bit of a mystery. I hope over the next few years that we'll have more information.
Thank you very much.
Okay, thank
Dr.
you.
Flaherty, for